the hypopituitarism. This is under secretion of the pituitary hormones. So what are the causes of hypopituitarism? We have non-secreting pituitary adenoma or craniopharyngioma, and we have also brain injury, we have radiation, and we have other causes that are most important. The first one is Sheehan syndrome. Sheehan syndrome means what? Means postpartum hemorrhage. So during pregnancy there is induce of the pituitary growth. So postpartum hemorrhage means there is no sufficient blood supply for this increase in the pituitary size. This increase in the pituitary size leading to what? Leading to ischemic infarction of the pituitary, which will lead to increase susceptibility to hypoperfusion. Why? Because there is increase in the size of the pituitary because of pregnancy and postpartum hemorrhage, leading to infarction of the pituitary, which will present with what? Failure to lactate, absent menstruation, and cold intolerance. The second one is called empty cella syndrome. It's atrophy or compression of the pituitary, which will lie in the cella thoracica. So there is atrophy or compression of the pituitary. It's called empty cella syndrome. It's idiopathic and common in obese females. Due to idiopathic intracranial hypertension, leading to compression of the pituitary, leading to empty cella syndrome. Pituitary apoplexy, it's so important. Sudden hemorrhage in the pituitary gland. Why? There is previous pituitary adenoma, then there is sudden hemorrhage of the pituitary gland. There is sudden hemorrhage on previous pituitary adenoma, present with what? Sudden severe headache and visual impairment. It's called bitemporal hemianopia. Then diplopia due to oculomotor palsy. Features of the hypopituitarism. So in Sheehan syndrome, there is infarction of the pituitary because there is increase in the size of the pituitary, and there is no enough blood supply for this pituitary, leading to infarction of it due to postpartum hemorrhage and increasing in the size. The second one is empty cella syndrome, compression of the pituitary due to idiopathic intracranial hypertension. The third one is pituitary apoplexy. It's a previous pituitary adenoma. There is sudden hemorrhage on the previous pituitary adenoma, leading to sudden severe headache and visual impairment, which is well known by bitemporal hemianopia. Then the treatment hormone replacement therapy, because there is hypopituitarism. So you will give everything. You will give glucocorticoid, thyroxine, 6 steroid, and also human growth hormone. The second one is acromegaly. It's excessive growth hormone in adults. But if it's in children, it's called gigantism. Increase in the linear bone growth. But in adults it's called acromegaly. It's caused by pituitary adenoma. What are the findings? Large tongue with deep furrows, large tongue, frontal boson, then coarsening of the facial features with aging, deep voice, diaphoresis. Why diaphoresis? Because growth hormone will stimulate a sweet gland to increase in the size, leading to excessive sweeten. Plus it's diabetogenic. It's causing insulin resistance, which will lead to impaired glucose tolerance. So leading to hypertension. Also acromegaly leading to hypertension, left ventricular hypertrophy, diastolic heart failure. This is the most important one. diastolic heart failure. He will ask you about the cause of this. You will say diastolic heart failure. In cases of acromegaly, then the diagnosis depend on three. The first one, we said that growth hormone will go to the liver, leading to insulin-like growth factor release. The second one is failure of suppression of growth hormone when you give oral glucose tolerance test. There is failure of suppression of the growth hormone. The third one is pituitary mass. You will see it on MRI. So you have three. The first one, insulin-like growth factor from the liver due to excessive growth hormone. The second one is failure of suppression of the serum growth hormone by oral glucose tolerance test. The third one is pituitary mass on MRI. The treatment, you will do surgery, pituitary adenoma resection. So surgery, the first treatment. If there is no cure, you will give octreotide. Octreotide is somatostatin analog. We said that somatostatin will cause somatostatin will suppress everything like growth hormone. The second one is big visumant, which is growth hormone receptor antagonist. So you will cause antagonism on the receptor of the growth hormone to inhibit it. So big visumant or octreotide, somatostatin analog. Then the last one, dopamine agonist, cabergoline. So in the treatment, you have the pituitary adenoma resection or octreotide, somatostatin analog to suppress the growth hormone, or you will give big visumant, which is growth hormone receptor antagonist, or you will give dopamine agonist like cabergoline, because the dopamine will suppress it.